will present to you how we have managed the crisis in Paris, in fact. First of all, we have to know what are the different etiology of the cardiac arrest. As you know, we have directly related to the COVID infection, but it's one part of the problem, it's other part. Secondary to the treatment, and you know, probably in France, we have many questions about hydroxychloroquine, and probably it was used too much without any proof of science for this disease. And we know today we are probably deaf with the use of hydrochloroquine. And when you see the different meta-analyses now, we know some patients have some difficulty. Other problem we meet during the first wave of the COVID in March was the psychiatric consequence of the lockdown. We have suicide, intoxication, and various forms of violence. And at the end, we have exactly the same etiology of cardiac arrest as usual, like STEMI and everything. And if we have a better understanding of the etiology of the cardiac arrest, we can probably have better treatment of cardiac arrest during this wave. During this time, when we see the different literature, it was found doubling of the mortality rate during this wave. This is from south of the world. In 2020, they decreased by 2 the number of survivors. And what it was interesting in this study is they find a patient with a return of spontaneous circulation, a ROSC. When they arrive to hospital, they decrease the rate of survival if they survive to pre-hospital phase. That means probably a patient has some difficulty to survive when they have the COVID-19. And what's interesting is to know they have the same rate of coronarography or everything. That means it's not a problem of intensity of care, but really because the etiology of the cardiac arrest are not really the same of what we've seen every day. And one of the second point, and we work on, is in this study, they have no overloading of the pre-hospital system. Probably we discussed just after, because it was another huge question to say, is because you have not enough people to answer, to call, you have an increase of rate of cardiac arrest. There's no increase of incidence, but as you've seen just before on the previous slide, they decrease the survival rate. And one of the major parts was probably an increase of advanced life support during the care. And I think we can have a good understanding by some difficulty, for example, to the venous access. When you are dressed to protect yourself, you have really an increase of difficulty to have an access. One previously, now is 10 years ago, we do a study in my team when we use, you know, the protection CBRN, and what we seen intra-os bone was better than IV, because when you are dressed, you have no so much agility with your hand. And probably one of the way to have less time to do the care is to use more IO than IV in this time for cardiac arrest. What we've seen in France is the number, this different curve has a number of call to rescue. We are here in blue, it's firefighter with these two lines is firefighter, in fact, and the orange is police, and the major one was a medical unit, my team 1-5, and you've seen a large increase of call, not for everybody, just for medical things in all France. That means more 80,000 call by day, more than we do every day. You have a problem with my slide? This number, huge number, need to be treated, and this is why we have to think. This is all the call we have in Paris area. You can see the different departments in Paris area, and you see it's very interesting to see the COVID wave is not the same in the small area, and you have during few weeks different
Professor Lamhart, sorry, Professor,
yes?
we only see your first slide. I think you must go ahead with your slides in your presentation.
Sorry, what's happening?
Sorry, that we only see your first slide in the screen. I don't know if you are going ahead with your presentation, but we are only seeing the first one.
You see the second one now?
No, I don't know exactly what is happening, but the screen is freeze in the first slide.
I don't know what's happening exactly.
Okay, if this is the case, okay, so please go ahead.
We try to find a solution, because if you have not the curve, it's very hard to you to understanding what I explain. To be honest, you have a control.
Yeah.
Okay.
Now we see all the presentation.
Okay, now you see everything. Okay, we'll stay in this type. Is better. Okay. Sorry. Just I explained, we have a lot of call in medical call, in fact, and what is interesting is we have a lot of call, but in the small area we have not in the same time. That means we need to communicate everybody to be sure we can understanding what's happening to the colleagues just near than 5 to 10 kilometers, because we can predict when we have a wave and what we have to do for cardiac arrest. And when we saw all the call we have in Paris area, you've seen in red, this is a COVID call, but we have to take care of other one. And this is interesting is to see on the EMS dispatch what's happening. We have always a difference between the number of calls and when appears the patient. And this is a very important point. That means in your dispatch center, when you receive a lot of calls, you know 2 weeks after you have patient and really more cardiac arrest. And that means you have to treat all these calls to find if you have a patient, for example, with a STEMI or cardiac arrest. This is why we have adapt, because the first link of the chain of survival is the alert. If you would like to be sure you can receive an alert, you need to adapt your dispatch center. And this is why we adapt everything. And for example, I explained to you here how we adapt everything. And for example, we increase the number of calls we can receive, because after one day, we saw people cannot reach us because they are not able, the system cannot receive so much call. We have to increase the number of terminals can reach the SAMU. And we implement a voice service. That means when people call, we ask, this is for COVID or not? If not, we can take care of the patient like every day. It's a COVID, we have one dispatcher in the COVID room can do some triage. On this triage, what they're doing, they look for an emergency. If it's an emergency, this is an EMS doctor, take care. If it's not an emergency, this is a GP doctor, and they are helped by, for example, medical students to help us. And for the first time in an emergency dispatch center in France, we use a text message. That means when these people, the dispatcher, receives a call for COVID, and just people said, I just would like to advise, I have no criteria of emergency, they receive a text message, and the text message explain everything. And at the end of the message, they can ask, okay, I would like to be recalled by EMS, and we can recall, but not in emergency when we have time, in the first 12, in the 12 hours. And if they say no, we don't call back. And that's very important thing, because we can decrease by 10 to 20% the number of calls of the SAMU. And what is very funny is we use a system for cardiac arrest we developed in France of Life. We send text message to citizens to go to cardiac arrest every day. We use the same system to send the dispatch this text message. And we need to adapt a lot of new room. For example, this is a theater on the SAMU, and we transfer and crisis center, and we have a lot of new work dispatcher. And that means during the crisis, we have to increase each day or 2 days more and more room to receive all these calls. If you would like to treat a cardiac arrest, you need to receive call. And as a number, the survivor of cardiac arrest in Paris decreased a lot this year if we compare to the other year. And when we check, the incidence increased a lot compared to other years. A lot of people think it's because people cannot reach the EMS center, and this is why they lose some time. I think it's completely wrong, because when we check, when we have the peak of call to the EMS dispatch, it's 2 weeks before the peak of cardiac arrest. It's completely normal now. We're understanding more the disease. It's because you start to have the signs, and you be more severe 7 days after in the major part. And one of the major issue is pulmonary embolies, as you know, and probably these pulmonary embolies are peak at 7 days after the first sign. That means people call us because they have the first signs, and they do the cardiac arrest 7 days after. And this is a very good thing to know, because we have to know these points, because that means we have to treat and repair people in this call to the EMS to know who can have cardiac arrest. And to have more data about these problems of peak or to reach the dispatch center, when you check this publication from New York City, they have, like Paris, an increase of incidence and decrease of survival rate. And in New York, as you know, they do just 911 when they have a problem. That means it's not a problem of number or dispatch center, it's problem of the disease in the same way. And in fact, when we think about,
again, like most of your countries, and I'm sure in Spain we have different levels of restrictions. At the moment, we are at the highest level of restriction, which is level 5. What is level 5? It's pretty restrictive. The Irish population, we must stay at home unless our journey is essential. We can only exercise within 5 kilometers of our home. All shops are closed except for what is considered essential. The hospitality industry is closed, bars, restaurants, hotels. Sport has stopped other than elite sport, and religious worship is not permitted. The only difference from our first lockdown is that this time around the schools have remained open. As the father of 4 children, this was very welcome. And interestingly, the level of COVID transmission within our school system has been very low, which is good. So right now, we have come right down. We are have quite a low 14-day incidence, but 3 weeks ago it was very high. It was up amongst the high 600s per 100,000. So the restrictions that we are experiencing are working, thankfully. So moving to cardiac arrest and how we as an ambulance service managed it. I'm sure, like many of you, in the early part of this year, you had to think about what how you were going to respond to this in whatever healthcare situation you were in. Firstly, how can we protect our staff and our responders? And also how can we continue to deliver high quality care? And the big question for us was, do these conflict? And you know, if we put in very significant measures to protect our staff, would then that affect the quality of the care that we deliver to our patients and potentially affect their outcomes? So I'm just going to describe to you how our cardiac arrest management has changed over the last several months. So firstly, from a dispatch perspective, we have stopped giving pre-arrival instructions to do mouth-to-mouth ventilation. Okay, so in cases of cardiac arrest, if a patient or if a caller called and we determined it was a cardiac arrest, we would instruct the caller in both mouth-to-mouth ventilations and in chest compressions. That has stopped. It is now compression-only CPR, and we advise the caller to place a cloth over the patient's mouth and nose. Our responders, so our public health authorities in this country determined that chest compressions were an aerosol generating procedure. So from the start, all of our paramedic staff have been wearing full personal protective equipment for cardiac arrest calls. And again, you will all be familiar with this. For us, this would be a fluid repellent gown, an FFP2 or an FFP3 mask, eye protection, and gloves. So what we call full AGP PPE, and this is for all cardiac arrests. This caused some difficulties. Again, you will be familiar with this. It's can be quite hot working in that. And also when the ambulance arrives on scene, it adds to the time before you can begin treating, because there is a time delay as staff have to put on the personal protective equipment. And in some instances, the bystanders or the family members became upset by this because they felt that their loved one was being denied care because our staff were putting on all of this equipment. We changed and we taught our staff to minimize risk on scene. So we asked them when they arrive on scene, depending on what that scene might look like, to try and divide it up into 3 zones. So the hot zone is where the patient is. That's where the active resuscitation area, the active resuscitation is going on. And if aerosols are being generated, that is where that is the area of highest risk. So the idea is to try and minimize the number of staff, only having the necessary staff in that area and only having the necessary equipment in that area. And also if there are any family members or bystanders, they should not be in that area. The yellow zone or the warm zone is where we would have other than essential equipment. So where you would prepare your airway equipment, prepare your suction device, prepare your IV or your IO, prepare your medications. So that was done, you know, at a little distance from the active resuscitation area. And then the green zone is where, again, further away again, you would try and keep family there. This is where the documentation would happen. And if more staff were arriving, where they would don their PPE, or staff leaving would doff their PPE. So, and clearly that had to be adapted to whatever situation the crews found themselves in, and in some instances that was not possible. But we were trying to minimize risk to our staff and to try and put some order on how things were managed on scene. Our public health authorities here also determined that endotracheal intubation was an aerosol generating procedure. So we made an early decision to stop endotracheal intubation pre-hospital. And instead, we have been using supraglottic airways as our only airway adjunct. We had been using supraglottic airways for many, many years. We have two grades of provider. We have advanced paramedics and paramedics. Our advanced paramedics have the skill to perform and the training to perform endotracheal intubation, and our paramedics do not. So there was a familiarity within the service with supraglottic airways. But since March, we have not done any intubation pre-hospital. We also made some changes to our transport decisions. We have a termination of resuscitation on scene protocol that allows our crews to terminate resuscitation on scene, but we tightened this up to have an absolute prohibition on transport of any patient that was asystolic, with the exceptions that you can see there on the screen, namely children, pregnant patients, patients who are hypothermic, poisoning or overdose patients, and drowning patients. For patients with pulseless electrical activity, transport of those patients from scene to hospital, there is now a requirement that the crews must discuss that with a physician prior to transport. So they were changes to our procedures prior to COVID. We have a very well-established network of what we call community first responders in this country. So they are civilians, they are volunteers who live in their communities and who volunteer to become what we call community first responders. They get 6 hours training in basic life support, use of an AED, and they can give aspirin to patients with chest pain. We have about 250 groups, more predominant in rural parts of the country. We are quite a rural country, particularly in the western part of Ireland, with, in many cases, long response times from the ambulance service. So this was an excellent solution to cardiac arrest in rural communities where local people would respond, who would be alerted by us by text message and would respond to cardiac arrests and provide BLS and early defibrillation. And we made a very difficult decision to deactivate this network back in March because we felt that for these civilian volunteers to respond to cardiac arrest in a COVID situation where they would be doing aerosol generating procedures such as chest compressions, that it would not be the right thing to do to dispatch them. And we are just currently in the process of working with these groups to reactivate them in a very careful and very phased way, and training them in the use and wearing of PPE and how to don it and doff it. Disappointingly, of the 250 groups, we have surveyed them, and we reckon that about 2/3 of these will not return to responding. Many of them would have, their members would be older, or would have underlying health conditions that would make them higher risk from COVID, and they have made the very difficult decision not to return to responding, which is understandable, but which is disappointing. Just the only other thing that's interesting about the COVID era is that our coroners here, the legal system, have now accepted the pronouncement of death by both nurses and paramedics, which is something that was not the case prior to this. In this country, by law, only a doctor can pronounce death. A paramedic or a nurse can diagnose death, but from a legal perspective, only a doctor can pronounce death. And this change was driven by a reluctance amongst family doctors to attend cardiac arrests and pronounce death. So our coroners here have now accepted our paramedics and our nurses pronouncing death, and which has been very successful and has not had any problems. So just to come to the third part of what I'd like to share with you today is what our data looks like. So this is a comparison of the first 9 months of last year and the first 9 months of this year. And there are not that many differences. You know, one of the things that has come up in this country, perhaps it has in Spain also, is the mental health effect of COVID, and our mental health services have noticed a significant increase in requirements for their assistance, but that has not been reflected in our suicide rate. So where you see asphyxia, that's deaths from hanging, and overdoses, deaths from poisoning, most of which would be suicide, and we have not had an increase in that, which is good. We have had no change in the number of cardiac arrests where bystander CPR is performed, which is a little surprising. We expected that it would drop, but it hasn't, particularly when you consider our community first responders are no longer responding. And we thought that there might be a reluctance amongst the general population to do chest compressions when requested by the ambulance dispatcher, but that has not happened. There has been a drop in numbers transported to hospital from 40% to 32%, as you would expect. And so far, discharge alive from hospital has not changed. Now that comes with a proviso that the 2020 figures is making an assumption that if the current inpatients are discharged alive, which may not be the case. So it's probably a little bit early to make any definitive conclusions from this. If you look at the Utstein comparator group, which, as you know, is the bystander witnessed cardiac arrest with an initial shockable rhythm, again, the figures largely unchanged. There has been a drop where of that group, 28% last year were discharged alive, whereas to date this year, that has fallen to 25%. From 78 patients to 59 patients. Again, that's assuming that all current inpatients are discharged alive. The numbers are small, so I suspect we will need to you know, make a better assessment of that in the fullness of time. But there is a trend there to suggest that in the Utstein comparator group, the number of patients that are going to be discharged alive is going to fall. So to summarize, cardiac arrest in COVID has been challenging. I think everything in COVID has been challenging, to be honest, cardiac arrest particularly. So as an organization, we have adapted and we were very driven to make sure that our staff were protected from it as best as we could provide for it. And I think we have achieved that. And then getting back to the question I posed at the start, have we protected our patients? I think so. The figures would suggest that that if there is a drop in survival, it is probably small. But I think early days, and we probably can't make any real conclusions on that just yet. And that's me. And thank you very much for the invitation to come and speak with you. And I look forward to your questions. Thank you.
Thank you, Professor O'Donnell. Thank you for your presentations and also for to share with us your experience. Okay, next speaker, la siguiente presentadora va a ser la doctora Judith Sagardía, que es médico intensivista y neumóloga clínica del Hospital Nacional Profesor Alejandro Posadas en la provincia de Buenos Aires, Argentina. Judith, bienvenida a este congreso virtual y gracias por estar con nosotros. Cuando te podamos dar paso, ya tienes paso. Pues cuando quieras empiezas tú a intentar lanzar desde aquí.
A ver.
Grabarse.
Hola, ¿qué tal? Mi nombre es Judith Sagardía, yo soy médica del Hospital Nacional Profesor Alejandro Posadas de la provincia de Buenos Aires y miembro de la Sociedad Argentina de Terapia Intensiva. Formo parte del Comité de Reanimación Cardio-Cerebral de la sociedad. Antes de empezar, quisiera agradecerles a los organizadores por la invitación. Mi tema es reanimación cardiopulmonar durante la pandemia por COVID-19 en Argentina. Y dividí la charla en 3 partes. En una primera parte, resumidamente voy a comentarles cómo es la institución donde estoy. Después, una referencia a el tratamiento del paro cardíaco en la institución y después lo que ocurre en el resto del país. Bueno, empezamos. Este es mi hospital, es un hospital de la provincia de Buenos Aires, es un hospital nacional que atiende una consulta de demanda espontánea y derivación de un área de influencia de 6 millones de personas. Cuenta con 560 camas, 260 puestos de atención ambulatoria y 10 quirófanos. Es gratuito, es de alta complejidad, de agudos y público. Está dividido en sectores, que tiene un sector A y B que es pediátrico y maternal, es el sector materno-infantil, y un sector C y D que tiene un sector de adultos con atención de las salas de internación, unidad coronaria y terapia intensiva. En el Comité de Reanimación y Recuperación Cardio-Cerebral de la Sociedad Argentina de Terapia Intensiva, en donde me desempeño como directora, actualmente somos varios instructores, médicos y enfermeros certificados por la AJA en todo el país. Nosotros somos centro de entrenamiento de AJA y nuestro comité tiene más de 20 años de trayectoria. La misión principal del comité es la capacitación del personal de salud en la RCP básica y avanzada, y también colaboramos con otros comités en la capacitación de reanimadores legos en la comunidad durante los congresos nacionales. El coronavirus apareció en Argentina con su primer caso el 3 de marzo, de un paciente masculino que había estado de vacaciones en Europa. Esa misma semana el Ministerio de Salud publica dentro del caso sospechoso la persona que haya tenido fiebre, síntomas respiratorios y contactos confirmados o probables, o historia de viaje, o que haya estado en zonas de transmisión local de SARS. Estas zonas de transmisión local realmente después se fueron ampliando y actualmente en la definición incluye los síntomas como fiebre y síntomas respiratorios, pero ya la transmisión es comunitaria. El 18 de marzo, es decir, 15 días después del primer caso, ya se contabilizaban 97 pacientes con COVID en 11 jurisdicciones distintas y 3 fallecimientos. Es así que el día 20 de marzo el gobierno nacional, el presidente de la nación, decreta el aislamiento social preventivo y obligatorio que obliga a las personas a permanecer en sus residencias habituales o en el lugar donde se encontraban en ese momento, y solamente podían trabajar el personal esencial. También para esta fecha se suspendieron las clases de primaria, secundaria y universidad. En este gráfico lo que vemos es el ascenso lento que tuvo al principio de la pandemia en los números de casos nuevos por día. Nosotros actualmente, por ejemplo, para el 8 de noviembre tenemos 5.300 casos nuevos, pero al principio ese ascenso fue muy lento. Nuestro primer caso en el hospital fue el día 12 de marzo, y el segundo caso en el hospital